Thank you very much. First of all, it is a great pleasure to be here. I know Dr. Cigarroa, and I'm sorry if I don't name each and every one of you, but seeing Dr. Kaul here in the audience, Dr. Gupta, and of course, Dr. Cigarroa, it's a tremendous pleasure. I also want to introduce my co-host today and presenter, Dr. Ajay Tripuneni. He is one of your own graduates, and together we want to engage you in a conversation. So the idea of this program, which is the Mind the Gap session, is to address an important area of therapy and treatment for patients with atrial fibrillation. As you might all know, that there are a lot of new drugs and therapeutic avenues that one can pursue. And short of having the next set of guidelines that I'm told Dr. Cigarroa is working hard on, there are a lot of challenges of how to select these therapies appropriately for patients. And towards that objective, the American College of Cardiology has come up with a fabulous program that I've been involved with for the last many months, I would say, close to a year, with some resource and tools to standardize how we approach this important subgroup of patients. So that's what is on the agenda besides the menu this evening. And before I get started with the presentation and show you all the tricks in my bag today, I would like to share some housekeeping issues. You might have noticed that there are some clickers on the table. And irrespective of your stature at the university, I would invite each one of you to click on those clickers. They're completely anonymous, and your responses would not be tallied against your names and name badges. So please feel free to respond to those. So again, the clickers go off after every 5 or 7 minutes. And I would invite you that before you respond, you turn them on. You also wait for my cue, because I'm supposed to be your ARS personnel also this evening. And then after we have responded to this question, we'll move on to the next slide. This program is being recorded, so please be polite to me. And this is not something I've done for many, many times, but I hope to engage you this evening here. There are also evaluations that I would love for you to give some candid feedback, so audiences like yourself are not put through the same thing again. And we could make some significant changes to the program and make it and enrich its content. Remember that your ARS keypads belong to the organization, and please don't put them into your pockets at the time when you walk away from here. So those are all some housekeeping issues. And if I've done a good job, please do send an email to my wife. So the session today is on atrial fibrillation, abbreviated as AF, and evolving strategies in anticoagulation. And we will embark on this journey together. Here are some of our disclosures. I have a disclosure with Covidien. I'm part of their study team and receive consultant honoraria for being on their clinical trials adjudication team. And I also have some ownership interest in technologies developed by UT Southwestern Medical Center, which are all remote imaging technologies. And of course, I'm on the Speakers Bureau of Medtronic. Ajay will introduce his conflicts of interest when he gets onto the podium. The objectives of this course are twofold. First, we would like to implement and talk about evidence-based anticoagulation regimens for patients with atrial fibrillation and develop our preferences of therapy based upon a uniform assessment of their risks and benefits. And second, it is to recognize common barriers associated with managing chronic anticoagulation in this very difficult patient subset. The anticoagulation initiative is definitely a multidisciplinary effort, and that is the why, when I came in here first, I looked at the number of registrants at the back table. I can see there are cardiologists, internists, nurse practitioners, fellows in training, and mid-level providers who do participate in the care and making this successful for the patient. The purpose is to facilitate greater understanding of atrial fibrillation treatment options and practice patterns, and kind of get on a foot of acknowledging the barriers to implementing these therapies and implement, using the ACC tools, a universal way of approaching these. This initiative is building on existing resources that I would love to show you today, and these technologies are very exciting. First is the ACC risk assessment tool. I would be referring to some websites, and Jane Radford, who is the person organizing the brains behind this program, will hopefully make the websites available to you if you're not able to note them down. These tools allow us to calculate risks of patients in terms of their ischemic strokes using the CHAD score and the CHAD-VAS score, and also their bleeding risk using the HAS-BLED risk for bleeding. You are able to enter patient characteristics, get individualized annual risk, stroke, and systemic embolism risk, along with the risk of bleeding. So these tools allow you to use evidence-based guidelines in assessing risks for that particular patient who is in front of you. You'll be able to share these data with the patient and along with that with your colleagues and your referring physicians. The output presents antithrombotic therapy options and novel oral anticoagulants, which are now based upon few clinical trials which many of you are already familiar with, which is the RELY trial, the ROCKET-AF, and the Aristotle investigating dabigatran, rivaroxaban, and apixaban, respectively. You can email these individual patient results after completing the risk calculator tool, and the tool can be accessed from the website that I don't intend to click today, but I will show you the iPad version of this tool and how to use it as we move along. So with some help with our ARS colleagues here and technical help, we should be able to switch to the iPad. And this is the iPad I'm holding today, and this is the ACC Anti-Coag Evaluator. You can download this very easily if you type in this name, either on your app store or through a web link provided by the ACC CardioSource. If you can see onto your left, which is the first risk assessment tool for systemic thromboembolism and ischemic stroke, that is the CHAD score system. And based upon the preferences and clinical parameters included in this scoring system, you can click or unclick and uncheck each box and come up with a CHAD score, which shows up in the bottom panel. So if I click a patient who is 75 years of age and who has type 2 diabetes, we can assess the patient's CHAD score. This is just a simple demonstration of the usage of this tool. You can also use the CHAD-VAS score and add on the additional features with respect to the CHAD scoring system. And as the screen is being pulled up, I can tell you that by adding these tools on to the iPad screen, you're able to calculate the patient's CHAD and CHAD-VAS scores. The HAS-BLED risk score is a tool that will allow you to punch in about 8 clinical features or lab values. As you know, the HAS-BLED risk score includes the patient's renal function, liver function test, history of prior bleeding, use of alcohol, or use of other antiplatelet agents, namely NSAIDs. It's a very, very practical tool, and by again checking in the respective box, you can calculate the patient's HAS-BLED risk score. If you can imagine, why are we doing this? And I think one of the essential limitations of comparing outcomes of patients with anticoagulation is being who it is being given to. And these tools would allow us to standardize the risk assessments for our patients. I apologize if this is not projecting well. However, if we move on to the next slide, I think we should go back to the slide set and look at this onto the screen. I think if you look at the screen, you can see by putting in precise clinical characteristics of our patient, we can assess what would be the reduction in ischemic stroke risk or the associated risk of bleeding with using a specific drug, in this case, dabigatran, for our patient. So you start off calculating the CHADS risk score, the CHAD-VAS risk score, you assess the patient's bleeding risk, and then simply navigating on the left panel of this iPad, you can click on any drug that you would like to select for this patient and know the appropriate reduction in ischemic risk and or the bleeding risk. And again, I said that you can download this application from the cardiosource.org/applications. The anticoagulation initiative also would include a lot of tools and a lot of evidence and a lot of slides and presentations and journal articles, video presentation from experts, all that would be assembled in one tab, which is the http://anticoagulation.org.cardiosource.org. And I strongly recommend you to spend like 5 or 10 minutes looking at it and then sharing it with your colleagues. And what I will certainly emphasize by using it in our fellowship clinic at UT Southwestern, that now we are talking the same language. We do not have to describe our patients in great depth in terms of having long conversations. We can simply refer to them and what is their CHAD score, what is their CHAD-VAS score, and what is their HAS blood risk score. I think towards implementing guideline-based therapies, it is quintessential we utilize guideline-based assessment tools. Because without applying guideline-based assessment tools, guideline-based therapies may not be as useful. And I think that is a point that the ACC wants to bring home to you today. Finally, there are some additional advantages and development that is happening in this area. I have not had a chance to look at them personally, but I'm told that these resources are going to be launched at a unified website very, very shortly. And after the meeting, probably we'll quiz Jane Radford to tell us when that is going to be. So with that introduction, and let's warm up, let's grab your tools, which is your ARS response systems. Click them on and have the blue light up. And we are going to take some quizzes, and I will tell you when to enter your response. So currently, the instruction is simply to power them on. So power them on, and as I click the green arrow, I will ask you guys all to respond to it. And the question is, how many patients with atrial fibrillation do you typically see each week in your practices? Jane? So please go ahead and respond. I'll let it run for about 10 seconds and then stop, and we'll take a poll of how have you all responded or trained yourself to the use of this device. Let's take a look. So I think this was a test for all of us to see whether we are nifty and we can fully use this tool today. Jane, are you satisfied? You've done a good job. You can see majority of you have responded that you see about 5 to 10 patients a week. Wow, that is a significantly good number of patients that you would see. I'm going to click off from this and move on to the next question. What anticoagulants or antiplatelet agents do you most frequently use to prevent thromboembolic complications in the patients you just described and that you see in your practice? Aspirin plus clopidogrel, clopidogrel alone, novel oral anticoagulants, warfarin or others, and let me just click on the green arrow and see how you can respond in the next 10 seconds. So click your responses, please. I'll wait about 30 and then I'll switch it off. That's perfect. And let's take a look at the response. Wow. So warfarin is the predominant agent that is used in patients with atrial fibrillation in your practice, which is very similar to ours. Let's move on to the next question. Let me see if I can make this happen. Over the last 9 months, when appropriate for your atrial fibrillation patients, have you found yourself making any of the following changes? Switching some patients to the newer agents, switching most patients from the existing medication to the newer agents, no change in prescribing pattern, or you are awaiting new data? So let me click the green button again, and I'll invite you all to vote. And soon we'll get very much used to this. So 10 seconds. And let's take a poll. Wow, this is equally split. You guys didn't plan it on me, is that right? So most people feel that they may not have seen that they are switching some patients to the newer agents, and an equal number of you are awaiting more data. Hopefully today's presentation would be valuable, and we will bring you some new information that you may not have seen before, or a comparison of agents that you may not have looked at in that particular fashion. Final question, I think, what is the primary thing you might do differently in treating patients with atrial fibrillation? Are you going to increase your utilization of long-term anticoagulants in patients at risk with atrial fibrillation? Work to better assess their risk of thromboembolic complications? Explain to your patients more in greater detail the pros and cons of different agents? Better communicate the risk of stroke to your patients regarding atrial fibrillation and the importance of anticoagulation? And finally, that you feel comfortable where you are and you don't want to change anything. And please go ahead and respond right now. And in the interest of time, I actually will try to move fast through this. And again, the most significant number of you do believe that you would like to communicate pros and cons to with your patients and talk to them in greater detail. And hopefully, this presentation is going to be very handy in helping you to do that. What is the greatest impediment in your practice that allows you at this current point not to make these changes? So are you restricted by time? Do you have other issues and this is not a high visibility issue or great importance to you and your practice? Difficulty in changing patient behaviors, difficulty in getting patient to accept benefits of long-term anticoagulation, cost, monitoring issues, lack of data or experience, or finally, no change necessary. So please go ahead and respond to this. Well, I would suggest that you pick from the first 5. And I'm sure if many of you are married, you would have 2 options, and you have to pick one of those that your wife has already picked for you. So if you're used to it, pick from the top 5 now, and let's see if you can get this through quickly. So in the interest of time, I'm going to stop it at 30 again. Okay, and let's see. So E is cost of medication. I kind of guessed it. This is the same response we have seen at other institutions that I've given this presentation. And with this backdrop of knowledge, let's launch into our presentation. So the first, it starts off with a question, give it great thought, and deal with it as you would do in your practice today. A 72-year-old man with history of persistent atrial fibrillation for the past 5 years is currently being treated with warfarin anticoagulation and a beta blocker for rate control. He comes to you to ask about switching to a new anticoagulant drug that does not require INR monitoring. Given the following patient characteristics, in which setting would you switch the patient from warfarin to a novel oral anticoagulant? And be appropriate and be supported by clinical data? A, ejection fraction 30% with class 2 heart failure, normally functioning mechanical mitral valve prosthesis, and left ventricular hypertrophy with normal ejection fraction of 55% and a patient with chronic renal insufficiency with a creatinine clearance of 10 milliliters per minute. So take a few seconds to think through this. And I'm going to click the ARS system, and you can respond now. I'll give you about approximately 10 seconds. And let's take a poll. So appropriately so, most of you believe that ejection fraction and evidence of class 2 heart failure would be the guiding reason why you would use a novel oral anticoagulant if you were planning to switch the patient. And we'll leave it right there and not give a response to what others felt, but let's continue through the presentation. And this question that we are discussing today is really important because, as you have said, you see about 5 or 8 patients per week with atrial fibrillation, and you have to make these decisions very frequently. And your peers together, we see about 2.2 million patients with atrial fibrillation in the United States, and this number is expected only to grow to about 5.6 million by 2050. Above the age of 70, the incidence of new cases of atrial fibrillation is about 10% and a lifetime risk of 25%, and as expected, it does increase with age. The risk or causative factors for atrial fibrillation, and many of you are well aware, are hypertension, diabetes, congestive heart failure, advanced age, presence of valvular heart disease, history of myocardial infarction, pulmonary embolism, cardiomyopathy, lung disease, or hyperthyroidism. For lone atrial fibrillation, I specify lone atrial fibrillation. There are some advanced genetic studies that have looked at novel mutations with connexin 4-0, mutations and variants of potassium channels, and atrial natriuretic peptide frameshift mutation that have been associated in patients without structural heart disease. I repeat that is only true for lone AFib. This publication in JAMA from 1994 still holds relevance, as it suggests that the prevalence of atrial fibrillation is strongly tied to advanced age. And as you will see in the next slide, that the age group between 75 and above, the prevalence of atrial fibrillation and the new cases that we see with atrial fibrillation are equally distributed between men and women. An important fact that if 15% of ischemic strokes are due to cardioembolic events, that accounts to about 75,000 events per year, and majority of these events are associated with atrial fibrillation. The risk of stroke with atrial fibrillation is increased by about 5-fold, and this slide is particularly important for those who treat and take care of these patients. That I've already mentioned that the stroke risk is high in these patients, but the size of the stroke and the severity of the stroke that a patient with atrial fibrillation sees is much more intense and causes greater morbidity than any other cause of stroke. And I think that is an important reason why patients with atrial fibrillation should be very carefully assessed. And they should be assessed by using a standardized risk scoring system. And this is going to be a repeating theme this evening, because if we don't apply standardized tools, you will not be able to assess the true ischemic risk of stroke for the patient. We are going to go over the CHAD risk score and the CHAD-VASC risk score and illustrate some differences that you will see in using each one of those risk calculators. As you see, the CHAD risk score includes congestive heart failure for C, hypertension, advanced age above 75 years, diabetes mellitus, 2 points for prior stroke or TIA. There are some features that you and I might feel are clinically relevant that are not in the CHAD risk score, which includes the female gender, of course, thyrotoxicosis, echocardiographic variables like that increased left atrial size, structural heart abnormalities, especially hypertrophic obstructive cardiomyopathy and or presence of valvular heart disease. Irrespective of not including the last 5 factors, the standardized CHAD risk score, if you assemble them along a table and look at the expected rate of stroke per 100 patient years, as shown in the middle blue column, the adjusted stroke risk gradually and progressively increases with increasing values and severity of the CHAD risk score. On the right of that panel, I would like you to pay some close attention to the regimen of antiplatelet/anticoagulation therapy recommended based upon the CHAD risk score for reduction of stroke risk. As you can see, apart from patients with CHAD risk score of 0 or 1, who have a adjusted stroke rate of 1.9 or 2.8 times, there are no options for aspirin therapy for any of the other groups. This is going to be different if you use a different risk calculator, and I will spend some time illustrating the differences between the two risk assessment tools. So CHAD score of 0, one can use aspirin for thromboembolic and systemic embolic prevention, and for CHAD score of 1, the option exists between aspirin and warfarin. If you include the additional features that I mentioned, like the female gender, the age between 65 and 74, and include presence of prior vascular disease into the equation, we then come up with a more significantly different risk assessment tool, which is called the CHAD-VAS score. As you can see, the maximum number of points are 8. And let's look at the guidelines for antithrombotic therapy, here presented from the ESC, based upon the CHAD-VAS scoring system. And as you will see, except for a CHAD-VAS risk score of 0, all other patients who are assessed using this classification or risk assessment tool have a recommendation for the use of an oral anticoagulant therapy and not aspirin therapy. So let me pose for you, how and why is this clinically relevant? Ask yourself, you are assessing a 70-year-old woman with atrial fibrillation. And that patient, based upon the CHAD risk score, would be assigned a risk of just 1, is that right? 75 years, for example. And you could then choose to use aspirin therapy for that patient, as I showed you. However, if you assess that patient with the CHAD-VAS score, that patient would have a CHAD-VAS score of 2. And that would put that patient strongly in the category of treating with an oral anticoagulant therapy. So it does make a difference how you assess the risk of a patient. The historical evidence for warfarin, and it is not a surprise that majority of you use warfarin in your therapy, is very, very strong. These are some studies, a pretty comprehensive risk of studies showing the point estimate and the confidence intervals for the benefit of warfarin with or without aspirin therapy. And without going into the details of each and every one of this study, this is simply to portray that warfarin therapy is a really, really good therapy. And I think we need to have some very specific and strong arguments why to move away from it. And it is not surprise in your practice and in mine, warfarin still rules and is used in majority of our patients. The problem with warfarin is very well known to us. As you can see, on the y-axis is the odds ratio for the risk-benefit profile for both ischemic stroke and intracranial bleed. And on the x-axis are the ranges of the INR shown. And the shaded square box illustrates the therapeutic window. And you can see if you go below an INR of 2, ischemic stroke risk escalates. And if you exceed the INR of 3, you have a strong high risk of bleed. So that makes warfarin hard to institute, and it is not surprising that just about half of our patients are spend more than 70% of their time with a therapeutic INR. And I'm going to show you some of that data as we move through the presentation. Warfarin is also a difficult drug to use in many circumstances, especially because of its drug-drug interactions. I don't intend to put a whole list of such drugs, but I've tried to point out some important ones. With that drugs that inhibit metabolism of warfarin through the CYP2C9 pathway, like amiodarone, simvastatin, rosuvastatin, fibrates, some antibiotics, and azole antifungals do interact. There are caps in the highest doses of some of the statins you can use while the patient is on warfarin. The exceptions, of course, are pravastatin and atorvastatin. There are some additional drug-drug interaction, drugs that induce the CYP2C9 system, rifampin and many other anti-epileptic drugs, which are not mentioned here, can also decrease the effectiveness of warfarin. And finally, it does have interaction with thyroid hormones, and a full list, a comprehensive list of such interactions is available on the tool, on the link showed below. You can simply either remember the link or simply type in your Google search Arizona CERT, which will take you to this site, and you can have a very extensive list of such drugs and drug-drug interaction with warfarin. The point I want to get to quickly is this one. The x-axis represents the time spent in therapeutic INR range. And on the left bar are all patients. Then the next are patients that are followed by specialty anticoagulation clinics and or by community practice. As you can see, we don't really do a good job. And it is not the fault of the providers most of the time. It is just the difficulty with the drug and lots of interaction with dietary use of food and other medications. However, it is absolutely true that the amount of time a patient spends in the therapeutic INR range has an absolute a direct correlation with the number of events. Again, you're looking at a graph where the y-axis is telling us, showing us about cumulative survival, the odds for cumulative survival, and the x-axis looking at days from enrollment of this patient in the study. As you can see, each of these shaded lines indicate high, intermediate, low, or absence of warfarin therapy and the amount of time the patient spends with a therapeutic INR. You can compare the red line, which is less than 30% of the time the patient spends in the therapeutic INR range between 2 and 3, with a CHAD score of greater than 2. As you can see, the survival of these patients are much worse than those who spend about 70% or more. It is a very difficult target to achieve, and most of the clinical trials that I'll be showing did not ever reach this number. I'm not sure Dr. Cigarroa is going to include that piece of evidence in the guidelines that he's working on, but it is true that most of the clinical trials and randomized clinical trials achieved about 55 to 62% of patients who actually spend in the warfarin arm in the therapeutic INR range, which I think is very, very important. I will use this transition point to talk about I've talked about the limitation of warfarin, and let's transition into the novel or newer anticoagulation, coagulant therapies. There are two groups of such agents. Factor Xa inhibitors, the three candidate drugs that we'll be talking to you about are rivaroxaban, apixaban. Endoxaban is not yet available, but apixaban has recently been approved and may be available to you, not at our center yet. And the new oral 2A inhibitor, which is dabigatran, and we'll look at some clinical evidence how to use this drug, but again, pertinent to a clinical case. So please power on your ARS handsets and tools. And we are going to talk about a patient who is 67-year-old. She's a female and presents with dyspnea. Please pay close attention to each and every syllable on this slide, because they are all there for great importance. So this patient has shortness of breath, dyspnea exertion for several months. The patient denies palpitation, chest pain, or dizziness, and her past medical history is suggestive, is significant for obesity, carotid artery disease with carotid endarterectomy, hyperlipidemia, and degenerative joint disease, which has led to the use of antacids and NSAIDs, celecoxibs, pravastatin, aspirin, diltiazem. She does not smoke or does not drink. So I'm going to leave it up for a few more seconds for you to absorb this information. And on physical examination, apart from an irregular pulse, her exam is pretty normal. Her ECG data is shown below. She has atrial fibrillation with a controlled ventricular response. Her creatinine is 2.1 with an estimated GFR of 23 milliliters per minute, and her liver function tests are normal. Her chest X-ray is suggestive of mild cardiomegaly, and on stress echo, she has a normal LV function, mild LVH, and no significant valve disease or no ischemia. And Dr. Kaul hopefully will not ask me why she required a stress test, but let's assume that she did. That will be a hard one to take. So what is her risk of stroke? Is she at a high risk of stroke, 8 to 18%, medium risk of stroke, and low risk of stroke? So please replay quickly in your mind the CHAD and the CHAD-VAS score, and we will leave the answers at the very end of the presentation, but let's take your responses now. And we'll go through 10 seconds of responses here. Okay? So high, 24%, medium, 62%, and low, 14%. Jane, if you can just note this down, we might have to get back to this at the conclusion of my part of my presentation. So let's review again briefly the indications and the CHAD score. Again, I mentioned before, the CHAD risk score of 0, you could use aspirin. If it is 1, you have an option between aspirin or warfarin, and anything above 1, you're committed to an oral anticoagulant therapy. Using the CHAD-VAS score, The patient, it includes presence of heart failure, hypertension, age above 75, diabetes, presence of stroke, TIA, or systemic embolism, female gender, remember, age between 65 and 74, which is exclusive with if you give the patient an age of greater than 75, of course, and presence of CEA and carotid endarterectomy that gives this patient a number 1 point for presence of prior vascular disease. So some tips if you want to recalculate your scores. And if you have done so, and you come up with a CHAD risk score which is greater than 1, greater than 0, you will have to treat this patient with an oral anticoagulant. Again, I don't want to give you these answers, and we will go and take care of this at the end of the presentation. So based upon what I've told you, and solely based upon what I've told you, try and assess the patient's risk of bleeding with the use of an oral anticoagulant. So power up your ARS tools. I'm going to click go here, and you are welcome to vote as soon as this comes up, the clicker comes up. So give me one more second here. Okay, here it is. Please respond. What is her risk of bleeding with anticoagulation? Okay. Medium. Okay. I think we are all moderates here. Huh? We don't want to be on any extreme. So I think we will record this response too, and we'll look at some numbers, how we would actually go about calculating the Hasbled risk score. As you will see, you don't have to really remember this. This is exactly what you do in your clinical practice. You're simply giving it a numeric value. It includes presence of hypertension, uncontrolled hypertension, abnormal renal function, abnormal liver functions, age above 65, prior stroke, history of prior bleeding, poorly controlled INRs, patient taking NSAIDs. Remember, this patient had DJD and was taking celecoxib, and of course, alcohol intake. And I think it is also important to point out that many of these features that put patient in the category of higher risk of bleeding also make the risk of stroke equally high. So I think this is an easy way to summarize that the patients who are at a higher risk of stroke are also those who could be or might be at a higher risk of bleeding. So another opportunity to recalculate your Hasbled risk score. And if you have done so, try and respond to this question: what is her risk-benefit ratio in terms of our risk of stroke or overall bleeding? Let me read out the options for you because it's a little complicated the way it is worded. CHAD score of 0 with an annual strict risk of 1.9. CHAD VASC score of 3 with an annual stroke risk of 3.2. And a Hasbled or a Hasbled risk score of 3 with an annual risk of bleeding of 5.6%. So please go ahead and type in what you think best characterizes the risk of bleeding or stroke from the 3 options provided. I'm going to stop it here. Let's take a poll and see what we have chosen. So most of us do agree uniformly that this patient does not have a CHAD score of 0. About 47% of us, equally split, believe that she has a CHAD VAS risk score of 3 or a Hasbled risk score of 3. And I think both are partially correct. And let's go ahead and calculate this through our tool. If one has chosen and assigned the patient this risk score, what would be the therapy you or each one of you would select for this patient? And again, give me a second to click on the red bar, on the green bar, and please go ahead and vote now. Okay, I'm going to stop it here. A fewer number of responses than usual, but let's see. Warfarin therapy, 77%, and a minority of people would actually pick a novel oral anticoagulant. So let's take a look. What would be the impact of using each one of these scores? These are 2 very important studies. I can tell you that I was not aware of this before I started giving this presentation. And in the last many months, I've read this over and over again, and it is really true that the calculation of the CHAD-VAS risk score makes a greater difference in women than in men. And you can look at this bar graph. The dark blue are the CHAD scores, and the light blue are the CHAD-VAS scores. The left panel is looking at women, and the right panel, which is the B panel, is looking at men. As you can see, the estimates of score are different and exaggerated and greater and higher for women than for men. And similarly, the selection of therapies are greatly impacted in women. Again, the same color scheme with women on the left panel and men on the right panel. As you can see, the recommendations for oral anticoagulant therapy for stroke prevention in women using the CHAD-VAS score can be significantly different. And that is one of the reasons why we are talking about this over and over again. So let's plug in the factors about this patient on our tool. And this is a slide created from the same tool that you would be using if you had downloaded the app and worked through the app. As you can see, the patient we are doing the CHAD-VAS criteria here. She has history of prior peripheral arterial disease in terms of carotid disease, age between 65 and 75. So she was 67 years old, and she was a woman. And in terms of the Has-Bled risk score, she had abnormal renal function. Do you remember? She had creatinine clearance of 23, and she was taking an NSAID. So the CHAD-VAS score would be 3, and the Has-Bled risk score would be 3. And I think most of you got this absolutely on the dot. In terms of the selection of anticoagulation therapy, on the ACC app, you can select each drug and look at the relative risks and benefits in terms of the ischemic and the bleeding risks. We are not going to pay much attention to no therapy. We all agree that she needs therapy. However, many of us, and most of us, and none of us literally chose aspirin, so I'm not going to spend much time on aspirin. You can see her stroke risk, annual stroke risk with aspirin is going to be about 3.4%, though her bleeding risk is low. It is unacceptable, I think. With warfarin, with an INR maintained between 2.3, the patient's annual risk of ischemic stroke and thromboembolism using the CHAD-VAS risk is going to be 1.4%, which is a 60% relative risk reduction compared to no therapy. As you can also see that if you take the absolute risk, take 100 and divide it by the absolute risk, you can get the number needed to treat. And that is always very helpful to calculate whenever you're very unsure of what to do for our patient. If the annual risk of major bleed, which is the patient's annual risk of major bleed, not using the population average, but using the Has-Bled risk score, we assigned it at 3, is 5.6%. And this risk assessment tool takes into account the variabilities of INR that this patient might entertain if you decide to treat her with that. And the number needed to harm in this situation would be 20, again, calculated with a similar way as you did for the absolute risk reduction. Here is a chart that tells you what options and how would this patient fare if we are to use one of the two novel oral anticoagulants. On to your left is the 110 milligram BID dose of dabigatran. On to the right is the approved dosage of dabigatran at 150 milligrams BID. I'm pretty sure we are going to engage ourselves in a discussion of the benefits and risks of each of these drugs. Is it too hard to read, or guys can see it? Just say yes or no. You can see it. If you can look at the selection of the lower dose of dabigatran, offers a risk of stroke of 1.4% compared to 0.9%, with a 78% relative risk reduction with the higher dose of dabigatran. Onto your right panel. The price to pay is an annual patient's risk of major bleed of 5.6% compared to 4.5%. And I think that this is a difficult question. It is not an easy question to answer. However, I think that the regulatory bodies correctly, in my opinion, decided that the stroke risk probably the lowered stroke risk probably provides an absolute greater advantage in terms of the patient's morbidity rather than preventing 6 additional bleeds that would you entertain by using the higher dose of dabigatran. This is what the patient's response or reduction in stroke risk would be if one is to choose rivaroxaban or apixaban. Just briefly, this is data based upon the ROCKET-AF and Aristotle trials. As you know, both these drugs are now approved for prevention of thromboembolic complications. The stroke risk is going to be very similar, 1.4 or 1.1%. The bleeding risk with rivaroxaban 20 milligrams a day would be 5.6% in this patient with renal dysfunction compared to 3.9% with apixaban. You might be wondering, why am I referring to these drugs without really showing you the clinical trial data? I think the way we have structured this is to first show you the choices and selections in the context of a particular patient and then move on to the clinical trial data and then sum it up how these drugs compare in terms of their risks and benefits. So please be patient and let's work through these selections. So when using oral anticoagulants, what we designed to depict today, that it's a difficult balancing act between bleeding and risk of stroke. And these scoring systems, I'm sure you are now convinced, allow us to systematically and objectively and uniformly assess these risks. The active W warfarin versus dual antiplatelet therapy prevention trial is an important piece of evidence that has now been included in the guidelines. I actually get this question very frequently from my fellows: is dual antiplatelet therapy equally effective in reduction of stroke? Because there is now a 2B guideline statement both in the PCI and in the stable and unstable angina treatment guidelines in patients with associated atrial fibrillation. And I think this bears for us to spend some time and look at this data more carefully. So this is a graph of outcomes looking at the primary outcome of stroke, MIs, non-CNS systemic embolic events and vascular death, and the cumulative hazard of these events is portrayed depicted on the y-axis with the time in years on the x-axis. As you can see, the overall impact on reduction of the primary endpoint of this study was statistically significant and divergent over years with the oral anticoagulation therapy instead of dual antiplatelet therapy with clopidogrel and aspirin. So where does this data of the 2B indication of the guidelines that has confused a lot of people comes from? It comes from the assessment of the primary composite endpoint or reduction in stroke events in patients who are unable or unsuitable to use warfarin therapy. And as you see on this graphic, there is a significant and statistically significant reduction of primary composite endpoints as I described it before, and specifically for ischemic stroke. If one could use in patients unsuitable to take warfarin, simply dual antiplatelet therapy, and that is the reason it now has a 2B guideline indication by the ACC and AHA. How does the risk of bleeding change with dual antiplatelet therapy in this particular patient population? It is no secret that by adding aspirin and clopidogrel together, the overall bleeding events increase as percent shown over a year. It can be as high as 10% for any sort of bleed, but this does not refer to major bleed. And here is the infamous Class 2B new recommendation from the ACC and AHA, the addition of clopidogrel to aspirin to reduce the risk of major vascular events, including stroke, might be considered in patients with atrial fibrillation in whom oral anticoagulant therapy with warfarin is considered unsuitable, and I will not read the rest. And I think it is very, very important to highlight this because at least in our practice, when we track this, we see a fair number of patients who are left untreated with warfarin simply because they're considered to be adequately treated with dual antiplatelet therapy for stroke prevention. I'm sure we're going to get some questions about how to manage triple therapy. I'm prepared to answer them for you today. But I can tell you at this point that just giving dual antiplatelet therapy to patients who can take warfarin is not appropriate as per the guidelines. It just has 2B recommendation for patients who are unsuitable for it. So let's switch gears and just talk very briefly about dabigatran and the oral factor Xa inhibitors. The first is a brief synopsis of the RELY trial, which was a major trial with 18,000 patients with atrial fibrillation, non-valvular atrial fibrillation, who were randomly assigned to dabigatran 2 doses, 110 milligrams BID or 150 versus open-label warfarin therapy with a targeted INR of between 2 and 3. Very important, the mean CHAD score was only 2 in this trial. And by the intention to treat analysis, the 110 milligrams of dabigatran was non-inferior to warfarin. It was a non-inferiority trial, and I'll try to interpret this for you, how all this plays into our adoption of these drugs into practice today. However, the 150 milligrams BID dose was superior to warfarin. And I will show some more data. As I said before, that the therapeutic INR between 2 and 3 was maintained only in about 64% of patients. Before we go ahead and adopt this drug into our practice, it is worth looking at the kind of patients that were enrolled in this trial. The patients had to have atrial fibrillation, as I said, non-valvular, and at least one of the following criteria that would give them an average CHAD risk score of 2. Prior stroke or TIA, abnormal LV function. Remember, our first patient with dyspnea, abnormal LV function, and reduced TF, that would be a great therapy, and most of you picked an oral dabigatran potentially for that patient. NYHA class of 1, advanced stage, and if they are between 65 and 74, one of the following, following risk factors like diabetes, hypertension, and CAD. As I said before, there were important exclusion criteria that I'm not going to read. Creatinine clearance of less than 30 is probably the most important one. And finally, these patients did not have severe valve disease. Here are the primary results of this study. The cumulative hazard for the primary endpoint was significantly reduced with dabigatran 150 milligram BID compared to both therapeutic warfarin therapy and or dabigatran 110 milligrams BID, though the primary endpoint, the primary non-inferiority endpoint, was met by this trial, and I think that is the only way you can look at the higher dose of this drug and be compelled and be satisfied by the fact that the superiority endpoints of this drug was also met in this trial. So what are the relative pros and cons? So I would definitely like to draw your attention to this slide and walk through with me as I read out the numbers, because this is really important and this would really have an important impact on your practice. If you look at the 150 milligram dose onto the right of the screen, compare it with the 110 which is to the left, you will see that the overall relative risk of gastrointestinal bleed was significantly increased by the 150 milligram dose. The overall risk of major bleed was reduced with dabigatran 110, but it was no different than warfarin with the higher dose. So while you peruse and read this slide carefully, I'm going to summarize in few lines what I've just said. The 150 milligram BID dose of dabigatran provided a greater reduction in ischemic strokes compared to warfarin therapy and the 110 milligrams BID of dabigatran. However, it was associated with a significantly higher risk of gastrointestinal bleed and an absence of advantage of lowering overall bleeds compared to warfarin therapy. I think that is how one needs to interpret this. And I think Dr. Kaul is here. He could tell us firsthand how did the FDA interpret it. But I think the indication for approval of this drug at 150 milligram BID dose was primarily based on the fact that the greater stroke reduction with the higher dose of the drug was probably of much more importance. And that is why the currently approved dose of this drug is 150 milligram BID. So to summarize what I've just said, that the 150 milligrams BID was superior in terms of stroke prevention. It did have higher risk of GI bleed, and it was not better than warfarin in terms of overall bleeds. There is a 75 milligram BID dosage for dabigatran. And I get asked this question again. In the study, this drug dosage was not included. So the data for the use of the 75 milligram BID dose in patients with impaired renal function is derived from PK and dose ranging and pharmacokinetic studies that simply extrapolate the bleeding risk associated with this drug at different doses studied in the trial. So this is the PK data that is assembled from the clinical study and then extrapolated to derive the potential risk and benefit of the 75 milligram BID dose. This is not a dose-ranging pharmacokinetic study in normal adults, healthy adults. So I think this is how this data has been derived, but I can tell you there is an indication to use this drug in patients with abnormal renal function, a creatinine clearance between 30 and 50 BID. And I'm not going to spend more time. I'm really happy to take some questions about this. So the synopsis or the conclusion of the recommendation for the use of this drug in patients with atrial fibrillation includes what I've just said, the 150 milligram BID dose in patients who have except for patients who have hemodynamically significant valve disease, severe renal impairment, remember, under 15 milliliters per minute of eGFR, advanced liver disease, and in the rest of the patient categories, the 150 milligram BID dose and the 75 milligram BID dose in patients with impaired renal function, but creatinine clearance between 30 and 50 milliliters per minute. I just want to repeat that because at least in our practice, there is some still improper prescription of these drugs, though not significant, but it still happens, and I see them often, from time to time in my practice. Let's move on to rivaroxaban from the ROCKET-AF study. Again, a brief synopsis of this study. A large study with patients with atrial fibrillation, randomly assigned to rivaroxaban, 20 milligrams once a day versus warfarin therapy. The important feature of this trial is the severity of patients with a high CHAD risk score. And compared to the RELY trial with dabigatran and the Aristotle trial with apixaban, the ROCKET-AF trial did include a patient with a higher CHAD overall risk score, and the intention to treat analysis, rivaroxaban was non-inferior to warfarin therapy. And I think that is how I would interpret this study. The INR was therapeutic only in about 55% of patients. And the overall safety profile of this drug led to less fatal or intracranial bleeds, and that was the reason that this drug was approved. The overall cumulative event rate of the study are shown on this graphic. The events were analyzed per protocol and intent to treat. As you can see, they were statistically not significantly different, but they did meet the non-inferiority endpoint. And this is the intention to treat population. If you put together, again, the features of patients enrolled in a clinical trial is of great interest to me. I read that method section and the baseline characteristics of a clinical trial very, very carefully, because that probably gives us the greatest confidence where and when to apply this therapy. As you can see, the mean age was about 70 years. Most of the patients had persistent atrial fibrillation, and the mean CHAD score in both the groups was fairly high, close to 3.5. In terms of the intention to treat population, there was most of the patients, about 54.9% of patients had a history of either prior stroke or systemic embolism. Majority of patients had hypertension, congestive heart failure, 40% with diabetes, and other diseases like myocardial infarction, which is expected in this patient population, and peripheral vascular disease and COPD. Let's move on to the final study, the Aristotle trial. This was also a double-blinded phase 3 trial, which compared apixaban 5 milligrams BID to warfarin for stroke prevention in nearly 18,000 patients. Like the RELY trial, it included patients with AFib with at least one additional risk factor. The target INR was 2 to 3, and the primary endpoint was stroke and systemic embolism, and the primary safety endpoint was major bleed. Again, on this slide, what I want to emphasize that the mean CHAD risk score was 2.1, very similar to the RELY trial and very different from the ROCKET AF study. The mean age was 70 years, and warfarin-naive patients were about 40% in this study. This is the distribution and the characteristics of the patients. I would like you to pay attention to the number of patients with normal and impaired renal function. 40% of patients had mild renal impairment and about 15 to 16% with moderate or severe renal impairment in this study. The final primary endpoint in terms of stroke, ischemic or hemorrhagic or systemic embolism is shown here. The non-inferiority endpoint was met, as I initially said, and there was a 1.3% per year stroke risk with rivaroxaban, with apixaban compared to warfarin, which was 1.6, and the hazard rate is shown here of 0.79 with a confidence interval left to unity. In terms of the primary efficacy endpoints, these are the event rates in terms of percentages per year. Again, you do not need to remember these. The application will tell you exactly what is the risk of stroke for a particular patient that you are using in your study. It is equally important to pay attention to only one important fact on this slide, that unlike any of the other atrial fibrillation studies, apixaban was associated with an overall reduction in all-cause mortality, which was, at least to me, a little bit surprising. And as you see, there was a reduction in stroke or systemic embolism. However, there was a significant reduction in all-cause mortality, something that we have not seen in other trials. In terms of patients with bleeding, the overall reduction was seen with apixaban, a 31% relative risk reduction compared to warfarin therapy. Here are the distribution of events. As I mentioned, there was an overall reduction in the primary safety outcome of bleeding. There was a reduction in intracranial bleed, and unlike dabigatran, 150 milligrams BID, there was a reduction in gastrointestinal bleed, or I would say no increase in gastrointestinal bleeding. So I think there are some differences in each one of these drugs, and I'm going to show you some consensus slides that would put all of this information together. And just to conclude with apixaban, that there was a 21% relative risk reduction in stroke and systemic embolism, reduction in major bleed, and an 11% overall reduction in mortality. So here is a summary trial for dabigatran, 150 milligram BID, rivaroxaban, and apixaban. The mean CHAD score is higher with rivaroxaban. There is no mortality advantage with dabigatran and rivaroxaban, but there is one with apixaban. In terms of reduction in thromboembolic risk, there is a reduction in thromboembolic risk only with the 150 milligram BID dose of dabigatran and with apixaban. The only drug that has actually shown reduction in overall bleed is actually apixaban. As you remember that intracranial bleed was reduced with dabigatran, but not overall bleeding events, and gastrointestinal bleeding were excessive with the higher dose. With apixaban, there was an overall reduction in all-cause bleeding, and as was intracranial bleed that was reduced with all the three drugs. Importantly, most of the bleeds with newer oral anticoagulants are hollow organ bleeds, and most commonly it is gastrointestinal, and there was no increase in gastrointestinal bleed with apixaban, which was increased with both the higher dose dabigatran and rivaroxaban. So some whisker plots just to put this image in your mind. As you can see, in terms of overall reduction of stroke, the single largest absolute risk reduction is seen with the 150 milligram BID dose of dabigatran compared to any of the other agents. These are not head-to-head studies. These are just studies put together in terms of a meta-analysis. In terms of overall reduction in major bleed, the only drug that has shown the greatest reduction in major bleed, all-cause bleeds, is actually apixaban 5 milligrams BID. And if you put together a consensus slide of looking at all-cause mortality, again, apixaban is the only drug that lies to the left of Unity, and again has been is associated with an 11% reduction in all-cause mortality. All these drugs compared to warfarin have reduced intracranial bleed. The overall incidence of intracranial bleed is between 0.1 to 0.3%. Most of the bleeds are hollow organ and gastrointestinal. I would like to remind you that. Hopefully the ACC and the AHA is going to come out with a consensus statement that's going to put this all into one chart and one perspective and make the task of people like me much simpler. I can just go around showing one slide. This is actually an adoption from ESC, and the ESC has given it a class recommendation of 2A for the use of dabigatran at 150 milligrams BID. And it is accepted that the lower dose of dabigatran, 110 milligrams BID, may be used in patients who are elderly, defined as above the age of 80, who are using drugs that can interact with dabigatran, like verapamil, who have a Hasbled risk score of 3, and a moderate renal impairment between 30 and 49 milliliters per minute. For this final group, at least my personal position reading the literature is, and the ACC's position hopefully would be, that for moderate renal impairment, the 75 milligrams BID dose might be preferable. Only time will tell when the ACC and AHA guidelines come out. I think that would be slightly different from the current ESC recommendations of 2A for using 110 milligrams BID for this particular group. Where rivaroxaban is concerned, there's a 2A recommendation for use of 20 milligrams once a day, and a lower dose for patients who have a Hasbled risk score of greater than 3. Remember, a Hasbled risk score of greater than 3 gives you an annual risk of bleeding of greater than 5.6%, which is fairly high. Finally, the novel anticoagulants are not recommended in patients with severe renal impairment. I think I want to reiterate that. And I can tell you in our institution, about 3 to 4% of such drugs are picked up by a pharmacy where these drugs have been prescribed, and GFR has not been systematically followed over time. Because remember, this is a lifelong therapy for these patients, and patients with moderate renal impairment might progress. And I think it is very important to keep this in mind as we move down into recommended these drugs. So I'm going to skip to the final slide. This is a paper that was published in New England Journal of Medicine that summarized the use of dabigatran and warfarin in a large number of patients from a national healthcare registry, and for the first time assembled the data for gastrointestinal bleed and intracranial hemorrhage, and gave us an idea how do, in a particular healthcare system, use of warfarin versus dabigatran fare in clinical practice. I encourage you to read this article. These slides will be available to you through the ACC. I'll be happy to forward these slides to you. And before I go on any further, I would like to invite my friend and colleague, Dr. Ajay Tripunaneni, to take us through some cases. And by faring very well on these case discussions, you will do justice to my presentations. Hopefully, I've elaborated and repeated myself a few times to allow us to come up with the right answers that Ajay is going to ask. He's your homegrown hometown boy, so he's going to keep tabs of who is answering them right or wrong, and hopefully will share them with us later. I hope you enjoyed this presentation. This data is not easy to present. However, by making it clinically relevant, the ACC and jointly with Jane and many others besides me have worked very hard to make this a handy and nifty tool for each one of you to adopt in your clinical practice. So without further ado, Ajay, come on in and take it over. Thank you.
Thank you, Subhash. I'm Ajay Tripuneni. For those of you who don't know me, I graduated last year from OHSU. And as a fellow, the hardest thing was to present to Dr. Kao, Dr. Sigurova, and Dr. Gerard. So they gave me my word that they're not going to ask me any questions today because I didn't know that I would be standing in front of them this soon. So the first question we're going to start with is, by the way, disclosures. I do not have any disclosures relating to this particular talk, but I do have an ownership interest in a healthcare technology company. So case 2, an 80-year-old male with cholelithiasis. So based on just this one statement, his CHADS-2 score is 1. We don't know any other information, cholelithiasis. So it was recently diagnosed. He had a cholecystectomy plan, so it's definitely not urgent. It's an elective surgery. Surgeon requests peri-op cardiac management. So this gentleman has permanent AFib for more than 5 years. It is being managed with metoprolol and dabigatran. And his medications are metoprolol, dabigatran, lisinopril, and pravastatin. His vital signs: blood pressure 134/68, heart rate of 78, not in the hypertensive range, his blood pressure. Cardiovascular exam is irregular, no murmurs. EKG showed atrial fibrillation with controlled ventricular rate. His creatinine is about 1.2 and his creatinine clearance is 70, so above 50. So far we are good there. So in preparation for surgery, you should. So this is a 80-year-old male with a CHADS-2 score of 1 with a normal creatinine clearance and elective surgery. What would you do before the surgery? So the audience response, please power it on if it's powered off. Okay, here we go. Stop. Let's see the answers. So about 31% said they would go with B, and 65% said with C, stop dabigatran 2 days prior to surgery and check PTT on the morning of surgery. I think that's the correct answer based on the data presented to us so far. So let's see if I can advance this. So the pharmacokinetics of dabigatran. So the disappearance curve depends on the creatinine clearance. So when you have a normal renal function, it is almost gone out of your body in 24 hours. But if you have a creatinine clearance less than 30, which is stage 4 kidney disease, it takes about 2 days before it gets about 50% of the drug dose when you're giving it at 75 milligrams twice a day. And you can follow it with APTT, activated PTT, but it also depends on when he took the last dose. If it was less than 2 hours versus greater than 8 hours. And the time for discontinuation depends upon the nature of surgery, which was elective here. And if he has any bleeding issues, or if it was an urgent surgery, like an acute abdomen, you can dialyze most of the drug with removal of 60% of the drug in 2 to 3 hours. There's no specific antidote. They're trying to develop if I'm correct, an antibody to it as an antidote. So if you look at this curve, the average time course for effects of dabigatran. So this is the bottom one is the one with the normal function, and the top one is the one with the stage 4 kidney disease, creatinine clearance of less than 30. As soon as a patient takes the medication, you can see a immediate effect within an hour and a half, and you can see the PTT levels are much higher. But as time goes by, they tend to go down. And if your normal renal function, at about 1.5 days, you go to the baseline. And if you have abnormal renal function, it takes up to 5 days. So again, the importance is when you took it, when was your last dose, and what is your creatinine clearance. Those are the two things we look at. So the proposed algorithm for peri-procedural management of dabigatran is, before a procedure, you see what's the renal function, you determine the timing of the last dose, and based on those, you decide when to stop. If it's normal renal function, anywhere from 1 to 2 days, and then they also divided it by the risk of bleeding. The risk of bleeding is based on the type of surgery they're going through. If it's a low-risk surgery or a medium risk surgery and a high risk surgery. Low risk surgery is a cataract surgery or a skin biopsy, whereas a medium risk surgery is having a ICD, pacemakers, and a high risk is any surgery from top to bottom, neurosurgery, cardiac surgery, abdominal surgery, and even a joint replacement. In this paper, they consider it as a high risk surgery. So for those, you tend to wait a little longer. So for patients at high risk of bleeding, what you can do is, other than stopping the drug, you can also check a PTT. And usually PTT, if it's about 35 to 50 is normal, 50 to 70 is abnormal. And post-procedure, if the risk of bleeding allows, you can start it within a day. Keep in mind the rapid onset of action at 1.5 hours. If there's any delay in starting, always protect them for deep vein thrombosis in the interim. So the bridging algorithm, maybe this slide should have said interruption algorithm. Hopefully we don't have to bridge with all these neuroanticoagulants. So the neuroanticoagulants, the first thing you look at is the renal function. If it is low, less than 50, you try to stop anywhere from 5 to 7 days. If it is greater than 50, you stop anywhere from 3 to 5 days. And hopefully you don't have to bridge. Hopefully all these patients are non-mechanic, like non-valvular diseases. And if the risk is low, you don't have to bridge. Again, even if it's a moderate to high risk patient, means a CHADS2 score of 2, if you have to put them on heparin or Lovenox, you still have to deal with the same half-lives of Lovenox, heparin, have to stop them before. So it's better off for a short duration. If you don't bridge, you're always better off that way. And then post-operatively, you start as soon as the bleeding risk allows. All the new trials, the rivaroxaban trial, and then when they looked at the interruptions, 40% of the patients were interrupted for surgeries during the 2-year period. So there were about 8,000 interruptions in these patients. And they all, especially the rivaroxaban, there was about 6% chance of bleeding or stroke or events when you interrupt therapy for any reason. So now let's assume that this patient is taking warfarin instead of dabigatran. In preparation for surgery, again, this is the same 80-year-old male who is going through an elective gallbladder surgery. You admit the patient to the hospital, you stop warfarin and administer IV heparin until the morning of surgery. You stop warfarin 5 days prior to surgery and start low molecular weight heparin until the morning of surgery. You stop warfarin 5 days prior to surgery without bridging anticoagulation. So I'm going to start the audience response. Hopefully it's under 5 minutes. So please vote. So most of you got it right. It's 79% stop warfarin 5 days prior to surgery. So risk associated with temporary discontinuation of warfarin. After warfarin is stopped, it takes about 4 days for the INR to get to 1.5. And once the INR is done, 1.5 surgery can be performed. Again, I think a little bit of it could be operator preference. Some may prefer completely normal INR of 1.3. And then, therefore, if warfarin is held 4 days before surgery and treatment is started as soon as possible after surgery, you expect patients to be subtherapeutic 2 days prior and 2 days after, because we're talking about 1.5 when they take the time taken to go to 1.5. So this is the outcomes of temporary interruptions in rivaroxaban. In this one, 2,000 patients compared to warfarin, the risk of stroke is 0.2, 0%, 0.2%, 1.5%, and minimal bleeding is 0.3. So no matter if it's rivaroxaban or warfarin, you have similar risks. Then again, if you bridge them with IV heparin and you prevent 2 strokes in non-valvular AFib, and anybody with prior history of stroke, you prevent 4 strokes, but the risk of bleeding goes up 300. You have 300 events in each group who are on warfarin, who are on heparin. So the guidelines for perioperative management of AFib were anticoagulation may be interrupted for a period of up to 1 week for surgery. In high-risk patients who had prior stroke, TIA, or systemic embolism, unfractionated or low molecular weight heparin may be used. But if you think it's going to be very brief, I think in the Aristotle AF trial, the interruption was 6 days. The risk of stroke is very low. Then managing non-therapeutic INRs. So if you have a patient with INR of between 5 and 9, and if they have no bleeding, you can stop the next 1 or 2 doses of warfarin. You can monitor them more frequently. If you think the patient is at a higher risk of bleeding, such as their elderly patients, they may be taking periodic NSAIDs, you may decide to give them some vitamin K so that you minimize the risk of bleeding. So the bridging algorithm for vitamin K antagonist for warfarin is you assess the thrombotic risk. If it is low, you do not bridge. You stop warfarin 5 days prior. You check the INR on the morning of surgery. And post-op, you resume it as soon as possible. For a CHATS-2 score of 2 or a non-low risk, you stop warfarin 5 days. And here they're talking about if you have a mechanical heart valve, give low molecular weight heparin twice a day or IV heparin. And then if you have AFib or prior history of thromboembolism, you can do a therapeutic dose daily and a half a dose the day prior to surgery. And you can check the INR on the morning of surgery. For post-op care, it's the same as the low-risk patients. And so case 2 teaching points, warfarin. Most patients, unless they had prior stroke, TIA, or systemic embolism, do not require bridging of anticoagulation. Warfarin can be safely stopped for 5 days prior to surgery. For dabigatran, if you have a normal renal function, you can stop 2 to 3 doses for low-risk surgery and 4 to 5 days. So basically 1 to 2 days for a low-risk surgery and 2 to 3 days for a high-risk surgery. If you have a lower GFR, you just double up. You stop for low-risk surgery, you stop 2 days, and for a high-risk surgery, you do 3 to 4 days prior to surgery. Essentially, it's between 2 to 5 days before surgery based on the renal function. That's the take-home point for dabigatran. And what happens if patients are bleeding on these newer anticoagulants? If they have a mild bleeding, you can delay the next dose or you can discontinue treatment as appropriate. If they have a moderate to severe bleeding, I think they classified moderate to severe bleeding as greater than 2 units of drop or requiring 2 units of blood, and life-threatening bleeding is if they have symptoms or greater than 4 units of drop or 4 units of blood transfusions. So the first thing is supportive care, and then the next thing is if you know that they took overdose just 2 hours prior, you can give them charcoal. For dabigatran, you can do hemodialysis. For all 3, you can do prothrombin complex concentrate. But the problem is dabigatran is a direct thrombin inhibitor and acts downstream on the thrombin, whereas the 10A is upstream, and this prothrombin complex concentrate may not be efficacious on dabigatran. The study has shown otherwise, and I'll review the data in a second. And if it's a life-threatening bleeding, you can give the prothrombin concentrate complex, and but again, all of these are more supportive treatment. And so here, it's comparison between giving prothrombin complex PCC for rivaroxaban, the slide on the left, and the slide on the right is dabigatran. The patients who have a higher prothrombin time, PT, after they got PCC, they came closer to the normal. Patients with dabigatran who were higher even after post-PCC did not come back to the baseline. So in the WISE paper that I think came out in 2012, actually what they did was they gave human volunteers, they gave the PCC who were taking dabigatran, and then they checked their anticoagulation tests. They did not affect their anticoagulation tests, but they still had clinical benefit. So that's why in the guidelines, giving PCC for dabigatran is also allowed. So again, the algorithm for management of moderate to severe bleeding and life-threatening bleeding episodes in patients treated with dabigatran. You stop dabigatran, you identify the source of bleeding, you see when they took their last dose, you measure the PTT or hemoclot, I think that's more specific assay if it's available, and you measure the creatinine clearance and do the supportive care, and after that, if the bleeding stops, you don't do anything. If the bleeding doesn't stop, you go to the PCC, and I think it's about 40 international units per kilogram. I had never given PCC, by the way. This is all, I'm just presenting the literature here. And you have to give about 30 minutes for this to act before you embark on another step. If after 30 minutes, if the bleeding continues, you can give FIBA or FIBA. It's a factor VIII inhibitory binding activity. It's like a combination of all the factors. The downside of FIBA is if you give too much, they can get thrombosis. They can get a stroke or a heart attack. So 50 international units. You wait for half an hour, reassess the response. Then if they're still bleeding, then you can give the recombinant factor VIIa. So the PCC has either 3 factors in it that is available in US, or in Europe it has been available for 4 factors. The difference is PCC has factor 9, 10, and 2, whereas the 4-factor PCC has 9, 10, and including the 7 and 2. So I think the FDA may have just recently approved the 4-factor. So if you have the 4-factor, that's always more beneficial than the 3-factor because it has a recombinant 7 in it. And if the bleeding stops, if it doesn't stop, you can do hemodialysis and you can monitor PTT every 3 hours. And but if you have a life-threatening bleeding, if the patient presents to you with life-threatening bleeding, you can directly go to the FIBA or FIBA or the recombinant factor VIIa. Again, I've never had to use it. This is all from the literature. Has anybody used it here? Do you want to share any thoughts, Subhash, on that? Okay. So any questions and answers on this? So this is the Pinnacle data. I'm going to go through quickly. This is just to say, look at practices, risk of stroke assessment, and how many of them are on Coumadin. And I think Oregon is doing better compared to the national average. I think 65% of patients are assessed for the risk stroke. And if you look at down below, about 35% are on thromboembolic risk factor assessment, whereas nationally we're only 17%. Understand, yeah, and that's where this is from. So the case 3, a 55-year-old man with hypertension, diabetes who presents with palpitations. So CHATS-2 score of 2, he has palpitations. He has a mildly dilated left atrium, mild LVH, mild diastolic dysfunction. He was cardioverted to normal sinus rhythm after TEE, demonstrated no thrombus. He was started on warfarin. He was switched from amlodipine to metoprolol for blood pressure control and AF suppression.
Ajay, I think what we would like to do, I think this is fantastic. The cases are really bring home the message that we were trying to get across. But I think that one of the strong points of this program historically has been a lot of interaction and disagreement. So I'm here to stir disagreement, and if you don't mind,
please,
I would love to do that. Because, Ajay brought up a very, very important issue, and I just want to ask you, how many of you have actually seen a significant bleed with any of the novel oral anticoagulants in your practice? Because as you've seen, 17% of you responded. I remember that bar graph that you are using it, which is not small. So if you can, anyone has had experience with seeing this bleed and how you have managed it, just share your perspective. You don't have to be right, but we would love to get your perspective. I think there was a gentleman here, Jane.
Joe.
Why don't you take the, Joe, why don't you take the microphone and just tell us a little bit about the clinical scenario that led to that clinical bleed?
Yeah, so, I don't know if this is on. Oh, here we go. So, yeah, it was kind of a classic case of different healthcare systems not communicating very well. There's a patient we were taking care of that had colon cancer, but wasn't known in our system, and the patient didn't provide it, but it was known in another system. And he got placed on dabigatran while he's in the hospital being treated for a heart failure exacerbation. And then he promptly proceeded to bleed. And at the time he got transferred to the ICU because it was a significant bleed requiring several units. And he got PCC, which controlled his bleeding.
So it was a gastrointestinal bleed, you said?
Yeah, from colon cancer.
I think that is an excellent, that is exactly where I have seen it once also, but there should be a very good discussion between your users and your blood bank and those who are going to make these factors available to you. Because I can tell you that while I was sitting next to Dr. Kaul, he said something very important, that these drugs are not benign. These drugs can be associated with DIC and other issues and thrombosis. So I think the use of this drug and management of this patient should be very, very carefully orchestrated. And I think that is exactly why the mission of this presentation, Mind the Gap, is very apt. So taking that lead, let me ask you, what are the primary key areas that any one of you can pick up this microphone and respond to it, in which particular patient profile are one of those that we have picked here today that you have used dabigatran in your practice? So try to draw us a profile of a patient where you have, in your practice, used any one of these novel oral anticoagulants. This question has twofold meaning. Of course, we want to learn about your use and how you approach these drugs, but also to try and include these profiles into our future presentations. So please take the lead and tell us how and when and what kind of patients you have actually used this drug.
No one takes the lead. Can I pick on the fellows? At least the familiar ones.
Well, have the fellows ever prescribed in your clinics any of the novel oral anticoagulants? Have you? So if you are nodding, why don't you have Jane hand over the microphone to the gentleman onto your right? I think to his right. Yes.
We use dabigatran in the VA, as a choice for patients with new onset atrial fibrillation. Because we have to wait for therapeutic INRs to be, therapeutic for 4 or 6 weeks. So dabigatran save us the INR checks, and we can cardiovert them sooner than later. So I have that experience in the VA.
So give me a second to see if I understand you correctly. You just said that you have used dabigatran to facilitate early cardioversion without going through the hassle of managing someone's INR for 4 weeks. Is that correct?
Yes, provided that their kidney function is normal.
That is a very novel way of using it. But that is very clever. I am not sure if that strategy has been tested, but that makes perfect logical sense. Ajay, have you used it similarly?
I was a fellow too at the VA, and they were waiting for 6 months. They would wait, and their INR would go down, and then again wait for another month, their last INR would go down. And that's when Dr. Raid came up with the plan of using dabigatran. And pharmacy did give them a little trouble from the cost standpoint, but I think they were able to work it out.
So if this is a very interesting point, and I have never heard this before, and this is extremely innovative and very practical, but it does beg a question while you sip your glasses of wine, is that would you be comfortable cardioverting these patients on dabigatran without doing a transesophageal echocardiogram? So I know some of the data from the clinical studies, but how has been your practice? Are you comfortable with it, or you have brought them back and done a TEE prior to cardioversion, or it was not necessary?
We haven't done a TEE. We would be, comfortable.
I think, Ajay, you want to respond to it?
4 weeks.
So for Coumadin, you can check INR and you know they're subtherapeutic. But what about dabigatran? How do you know they're compliant? You don't. You trust the patient. But you can cheat by doing a PTT, but PTT is never like a foolproof. It's not reliable all the time. But when there's even a slight suspicion that the patient may not be compliant on dabigatran, it's always better to do a TE. But again, we have not done TE at the VA. Then the other important thing is you tell patients who are taking dabigatran not to use their pill boxes. They can't take the dabigatran pill and put it in their pill box. It degrades. It's not going to be efficient. It has to be in the same bottle it came in with. That's a really important point. Dr. Gerard, would you agree? Pass.
Well, so I think that, in your practices, I would like to, refer the next question to the nurse practitioners or nurses or mid-level providers who support the physicians. So, or nurses in the audience, have you encountered and how have you tried to educate and inform patients on these novel oral anticoagulants? As you can see from Ajay's presentation and hopefully the slides I showed you, there is a big learning curve in terms of being able to comply with these medications because there are no good tests to tell you if the patient is taking it. The second fact, I want to reiterate the slide that Ajay showed. A PTT is a good indicator for the disappearance of the drug. It is not a good indicator for the patient taking it. So again, these are key learning points that I think there should be very good communication. So if any one of the mid-level providers in the audience would just grab the microphone and share some of their experiences, troubles, advantages of using any one of these novel oral anticoagulants, I think it will be very, very helpful because this is the largest group of mid-level providers we have seen in many of our events. And what Dr. Cole said when he started, that this is a collaborative effort. This is not going to happen just because the docs or the fellows know exactly what dose to prescribe. So anyone wants to take the lead? I hate to interrupt you, but I will request you can take the microphone, please. We are recording you. You are on the camera.
Sure. The cost of each of those agents varies greatly if you're in private practice with the insurance. And one of the customary things that I always did was before I chose one, my secretary called their, if you can still call him the secretary, I'm that old, called the insurance companies to decide what the cost was, and it could easily vary from $15 to $200 a month for the same drug.
I think I lack competence to answer a cost question. I don't want to dodge it, but I think there are many more learned people in this audience who can address that, but that's a significant challenge, and I think we acknowledge that.
And for non-Medicare insurances, these companies sometimes give out like a $40 copay card or a $10 copay card. And I think there are no cost-effective analysis on the rivaroxaban and apixaban yet, but there are cost-effective analysis on the dabigatran. They've been done extensively. It also depends on, because these are all just over 2 years data, but it depends on what happens to the patient next. What is his risk over a lifetime? How many bleeding strokes did he have? Did he have embolic strokes? All of these change the cost-effective analysis quite a bit. The 2 studies they did was, I think it was $40,000 per quality of life for dabigatran when it came out, and it came down to $12,000.
So I think this has been a long evening. I know you all have had a very long day at work. And I think that before we end and part ways here, I think it is very important to draw a picture of a patient, of an ideal patient that we would consider these drugs. As we all agree that a vast number of our patients could do very well on warfarin therapy. So who is the ideal patient that should be considered for novel oral anticoagulants. So I just need from each one of the table, there are 6 tables here. If you can quickly go around and just say a profile of a patient, we'll start from the back table. You want to take a lead and pick a patient onto your, Jane, onto your left. Any one of the fellows want to pick a patient and draw a scenario that you would use rivaroxaban or dabigatran very quickly? Okay, why don't you answer yes or no? Go ahead, please.
Probably somebody who doesn't have a lot of risk factors for bleeding that we can easily identify, and maybe reliable in taking their medications from just a standpoint of talking with the patient, and not a lot of other comorbidities, but has enough of a risk factor profile that needs warfarin, that I would think would be okay for one of these other novel anticoagulants.
Fair comment, but let me draw on that. The patients at a high risk of stroke and systemic embolism are also at a high risk of bleeding. I think that is a very important point I want to leave you with today. And it is not always very easy to find a patient who is at a high risk of stroke, but is at a low risk of bleeding. That is not a very common. You will see in your practice that those two things go hand in hand. And at that point, one has to make a very conscious decision of which is the more or the higher risk. So I think that the number needed to treat or a number needed to harm is a very great way of converting percentages for a particular patient. So I would suggest start off with the CHAD score, calculate the CHAD VAS score, and you are using the ACC app, you will be able to individualize the reduction in the risk of bleeding or the exaggeration in the risk of stroke with either one of those agents or vice versa. So great answer, and thanks for taking the lead. I'm going to stop here. I don't want to pull on any one of you. I greatly appreciate you taking the time to spend with us. This is a fabulous audience, and I'm so proud to be here and meet such great folks in this audience, and each one of you. Oregon, as you know, is performing very well on the Pinnacle Registry. Someone just mentioned there are only 2 practices. Hopefully this lecture and this interaction can lead to expansion of such use of these drugs and inclusion and submission of data in the Pinnacle Registry. So thank you very much for having me here. One final announcement is that please do not forget to fill up your assessment forms. Your feedback is crucial and critical to this program. And as you can see, that many of the cases that have been put together here have been created based upon the feedback we received from the audiences. So once again, thanks for having me, and Ajay, thanks for hosting this event here. Thank you so much.